Good evening to all. Thanks for joining for the first edition of this ECME. I think it's Professor Epan's idea that we should start a program which will be inclusive of all the DNB trainees who are all over Tamil Nadu. We've been running monthly CME programs for many years now, which probably is really confined only to people who are in Chennai. As I look at it, I think Tamil Nadu is about training about 60 postgraduate students every year. That comes to about 180 students a year, out of which about a half of them are out of Chennai. So I think this will provide a good platform for all the postgraduates to have a chance to present their cases, and it will hopefully be a good academic feast. And as Dr. Epan has suggested, probably we'll have a couple of case presentations and a lecture from a guest faculty who will be invited for the same. Since it's already a packed program, I invite you all to this first edition of this ECME, and I'll request Professor Epan to take over for further proceedings. Thank you.
Thank you, Pirama. As Pirama mentioned, this is truly history in the making, and it's a very nice initiative supported wholeheartedly by everyone in the TNISG Governing Council. It is hoped that different cities or districts outside of Chennai will host this by turn and enable the students and teachers in those regions to take charge of that part of the meeting. Also, it's an opportunity for everyone to see each other. It's a two-way seeing, and it's surely nice, and it's bound to have benefits. So without much ado, I will once again welcome all of you for the program, and I'll ask Ashish to MC us through. Ashish, go on.
It's me too. I should
Yes. Please, sir.
Talk few words.
Yes, sir.
So I would like to welcome everybody. I think I would like to congratulate Dr. Epan and Pirama for the new initiative. I think this will really help our postgraduate, not only our state, outside. Future, I think probably we can even invite speakers from outside Tamil Nadu as well as overseas. I think it's a great initiative. I would like to wish this great initiative a great success.
Thank you, sir.
Can I invite Dr. Uday Zakaria, Vice Principal, for his initial comments?
Thank you, Ashish. Thank you, friends. On behalf of the Principal of CMC and the Medical Education Department, I want to thank TNISG for this initiative, and especially for the support from our patron, Professor Palnisamy, our Secretary, Dr. Piram, and President, Dr. Epan. In this format, what we see is inclusivity and empowerment. And this is something that our state has been at the forefront, and I hope that this continues. I specifically want to thank so many people for joining in, and for the external speakers, Professor K.T. Shenoy, who I may add on as a personal note was my examiner for TN. So welcome, and we'll continue.
Thank you, Uday. I think we have a packed program. We will immediately go to the cases, and we have two interesting cases, one from gastroenterology and one hepatology. For the first case, can I request Dr. V. Jayanti, Dr. L. Venkatakrishnan, if he has joined, and Dr. Arvind, to please share the first case. And I think Dr. Ashish Chaudhary from CMC Vellore will present the first case. Over to Ashish. Can we have Ashish slides, Ashish Chaudhary?
While Ashish comes on, I will just have one-line introduction of the moderators as well. So Dr. Jayanti has been in multiple academic institutions. So she has been in Stanley, in Coimbatore Medical College in the government sector, following which he's had a stint in SRMC and established the Department of Hepatology there. Dr. L. Venkatakrishnan heads the Department of Gastroenterology at PSG Coimbatore, and Dr. Arvind is currently the Dean of Tiruvannamalai Medical College. I think, welcome. And Ashish Chowdhury, you can start.
Good evening, everyone. Am I audible, sir?
Yes, you are audible.
Yes, sir.
Your slides on slideshow.
Yeah.
And start.
So one 52-year-old gentleman, Mr. X from Ranchi, presented with chief complaints of recurrent oral ulcer for last 1 year, multiple small and large appendicular joint pain for last 8 months, pain over the leg, thigh, arm, and forearms for last 8 months, tingling sensation in bilateral hands and feet for last 6 months. There is no history of recurrent genital ulcers, difficulty in getting up from supine position, breathlessness, nasal ulcer and discharge, skin lesions, and weight loss. There is no significant past history. There is no family history of malignancy. So based on the presentation, our syndromic diagnosis was inflammatory polyarthritis with recurrent oral ulcers with peripheral neuropathy and muscle pain. Our differentials were autoimmune diseases like rheumatoid arthritis and mixed connective tissue disorder, vasculitis like Behçet's disease, granulomatosis with polyangiitis, microscopic polyangiitis, and paraneoplastic diseases. Coming to the examination, vitally the patient was stable. In general examination, pallor were present. Rest of the examination in general examination was normal. In systemic examination, all the systems are normal apart from the nervous system, in which we found the pain and true tongue sensation was decreased up to the bilateral knee level. In tongue, there was 2 into 0.5 centimeter ulcer along the left lateral border and another ulcer of 1 into 0.5 centimeter along the right lateral border. So after the examination, our differentials were same. Coming to the baseline investigation, patient had normocytic normochromic anemia. ESR and CRP were elevated. CPK was elevated. ANA was negative. Stool occult blood was positive. So in view of anemia and stool occult blood positive, we went ahead with gastroscopy. Gastroscopy showed superficial ulcers and erythema in the antrum and erythematous nodular lesions in the duodenum, biopsy of which was suggestive moderate chronic active duodenitis and moderate chronic erosive gastritis. Subsequently, on 26 June, patient developed hematochezia with hemoglobin drop from 7.5 to 6.2 gram per deciliter. Subsequently, patient also developed AKI with rise in creatinine, serum creatinine, and hemoptysis with acute breathlessness. Why we suspected diffuse alveolar hemorrhage in this setting? Because there was increase in the opacities in the chest X-ray, and one bronchoalveolar lavage was done, which showed hemorrhagic fluids, and the bowel fluid analysis was suggestive of hemosiderophagus. Now coming to the syndromic diagnosis. So the patient had rapidly progressive renal failure, patient had GI bleed, probable diffuse alveolar hemorrhage, arthritis, and peripheral neuropathy. So with combination of all these features, we suspected probable vasculitis as the underlying etiology. Patient, so in view of the hematochezia, we did one colonoscopy which showed multiple ulcers from the distal 20 centimeters of the ileum. Segmental biopsy was done, which was suggestive of fibrinoid necrosis with transmural neutrophilic infiltration in the vessels wall in the submucosa with fibrin thrombi in the vessels. Patient had persistent bleed while on immunosuppression. Patient was started on methylprednisolone followed by oral steroids. With that also, patient had persistent bleed. So on-table enteroscopy was done. It was found that multiple ulcers noted from 250 centimeters distal to the DJ flexor till the IC valve. So patient underwent limited right hemicolectomy with end ileostomy. Biopsy of the resected specimen showed the same features like multiple deep ulcerations, thick walled blood vessels in the submucosa with fibrin thrombi and occasional multinucleate Jann cells. This is the serum creatinine trend, which shows after the initial 5 to 6 days, the serum creatinine jumped from normal to up to a maximum level of 6.12 milligram per deciliter after starting pulse steroid, and the patient required 7 sessions of plasma exchange also. After that, the serum creatinine gradually became normal. After surgery, the bleed settled for some days, but it recurred again, required multiple transfusions. So retrograde double balloon enteroscopy was done through the stoma. So it was seen that up to 100 centimeters it was normal, but during the procedure, patient developed pneumoperitoneum and cardiac arrest. So iatrogenic bowel perforation or abdominal suicide dehiscence was suspected. But as the patient was very sick, so further imaging or surgery could not be done. And the patient was discharged at request in terminal state. So the diagnosis of the case was rapidly progressive renal failure, GI bleed, diffuse alveolar hemorrhage, arthritis, and vasculitis workup, anti-PR3 antibody was more than 200. So it was anti-PR3 vasculitis, that is granulomatosis with polyangiitis, and treated with steroids and 7 sessions of plasma exchange, underwent limited right hemicolectomy with end ileostomy, and developed pneumoperitoneum during double balloon enteroscopy, probably due to perforation or abdominal suicide dehiscence. So the learning points are patients with multi-system involvement and GI bleed, vasculitis should be kept as a differential from the beginning. As it generally involves long segments of the gut, medical therapy plays a major role, except in cases with bleed from a localized area of involvement, and multidisciplinary input and management is required for the treatment of this type of cases.
Do we have any imaging of this patient?
Yeah, ma'am. Imaging was there. CT
No,
enterography was
CT.
done, ma'am.
CT imaging.
CT enterography was done, ma'am. That showed thickening and wall enhancement in the terminal part of the ileum.
Just wondering, the patient was asymptomatic otherwise with no overt GI bleed, no melena. Can you consider the possibility of a polyarthritis nodosa in this patient? ESR was 152, I think.
Yeah, ma'am.
And there's a renal involvement.
Yeah.
And, it can also cause vasculitis.
Yeah, ma'am.
So, any possibility of a polyarthritis nodosa as a DD in this patient?
Because there was lung involvement and polyarthritis nodosa usually does not involve the lung, so we kept a lower differential.
No, what I thought we could have the CT imaging just to see what was happening to the intestine and what was the imaging in the during the arteriogram. If there was a CT angio, because the patient is having bleed.
We have done CT enterography, ma'am. We have not done CT angio.
I think, ma'am, CT didn't show any major arterial involvement. So aorta was uninvolved. So we didn't think of large vessel vasculitis, but a small vessel vasculitis.
So normally, what is the literature say for this management of such conditions? Generally, it's only steroid, is it?
Ma'am, initially, we have to give pulse steroids followed by oral steroids at a dose of 1 milligram per kg body weight. And we can subsequently, with severe diseases, we can start either rituximab or cyclophosphamide.
What I want to know is, basically, there are ulcers in the GI tract, right from the oral cavity, in combination with renal involvement. No, so a DD is somehow restricted to that with joint involvement.
Yeah.
So in that context, what would be the treatment protocol? Should we have gone for biologicals or something like that? I do not know.
Treatments, two treatment options are there, ma'am. Either cyclophosphamide or rituximab. Cyclophosphamide is better in patients with renal involvement as compared to rituximab.
I was just thinking, why was it not considered?
I think we were guided by the nephrology because of rapidly progressive renal failure, which was basically one big problem for this patient. And they preferred steroid induction. And then a patient was operated soon after. So we were considering rituximab, but we had steroids with plasma exchange.
Urine was normal. Urine analysis.
Urine, there is RBCs, man. 9 RBCs for high power field. Protein was 1+, man.
It's more of a nephropathy, is it? Or glomerulosclerosis? What type of injury they suspected? The kidney? Creatinine was high, and you said it was progressive. But what was the possibility? It was glomerulosclerosis or glomerulonephritis, or what was the DD they considered? Because proteinuria is also not so much, no?
Yeah, ma'am.
So is it just part of the loss of hemoglobin and then secondary anemia, or?
Yeah, ma'am.
And what is the role of PLEX? I was just wondering in this patient, no? What was the aim of doing PLEX in this patient? what was the basis of Plex in this patient?
I would think, ma'am, Plex was as you would have suggested, rituximab. It was a B cell problem. So preformed antibody would be removed by plasma exchange, ma'am. So it was used as an immunosuppressive therapy under nephrology, not under us.
Interesting case.
Can I request
Yeah.
Dr. Arvind also for his comments? And
A biopsy from the tongue also would have been useful, no? That would have given us more
Yeah,
information.
biopsy of the tongue was not done.
Dr. Arvind?
we are not able to hear you, sir.
Dr. Arvind, unmute and speak, please. We can't hear you. We can move on.
Okay. I'm not sure whether LVK sir has joined this, but maybe he can moderate the second case. Can I request Dr. Alagamai, who is our alumnus and up and coming
Ashish Uday here.
Hi, Uday.
There was a question from Dr. Ubal in the chat box.
Yes.
I think he basically asked about why we went ahead with a heavy colectomy and what was the need for a double balloon.
We can,
During the hospital stay, sir, patient developed hematuria. He required multiple transfusions. With immunosuppressive therapy, renal functions improved, but there is no improvement in hematuria and requirement of PEG cells. For that reason, colonoscopy also showed ulcers, and during colonoscopy, we could see blood coming out from the IC valve.
so maybe in the hindsight,
so we went ahead with enterotomy, laparotomy, and enteroscopy that showed multiple ulcers with oozing in the small intestine. After that, patient underwent limited right hemicolectomy with resection of the involved small bowels.
Any role for APC in this patient? I do not know. I'm not experienced on that. I was just wondering whether, because more of a general ooze, so would APC would help to this patient?
I think it was diffuse involvement, ma'am, within the small bowel. Almost 100 centimeter of small bowel was involved. So difficult endoscopically.
But in a diffuse disease and a systemic disease, I think surgical or focal therapy may be not indicated or not warranted. In this case, ideal will be either IV immunoglobulin or a rituximab or cyclophosphamide. Those kind of, because basically any vasculitis with the GA involvement is a bad prognosis, particularly the GA bleed, it is a prognosis is very, very dismal actually. So rather than a local treatment, maybe more aggressive immunosuppressive therapy, we should have an ideal option.
I agree, Dr. Ubal, definitely. I think hindsight, we should also have thought about more aggressive immunosuppression here.
Dr. Arvind had brought out that because of the renal and lung involvement to consider good pastures.
Anti-GBM antibody was negative, sir. We've done.
IgG? IgG?
Immunoglobulins was 3.7, ma'am. Globs was IgG done, Ashish? We can.
IgG was not done separately.
Okay, I'll move on to the next case. I think very interesting discussion here. Thank you, Ashish, and thank you, chairpersons, for leading the discussion. For the next case, can I invite Dr. Alagamai, Meenakshi Madhurika Medical College, and our alumni, up and coming gastroenterologist from Tamil Nadu ISG, and Dr. Jayaprasad, who has kindly joined us as he's an associate professor, Government Medical College at Tiruvannamalai, and one of his student, Dr. Ikram Hussain, he has been posted here for his peripheral posting, and he is going to present the next case.
Good evening. Good evening to everyone. I
Can
hope
you-
I'm audible.
Can you put your slides on slideshow, Vikram?
Yes, sir.
Ikram, I think multiple mics are on in your room. Can you please make sure everybody is muted then?
Yes, sir.
Okay, Ikram, please.
Yes, sir. So this 58-year-old businessman who came with the complaints of painless abdominal distension for the past 1 month, which was gradual and progressive. He underwent therapeutic paracentesis and was started on diuretics. Outside USG showed coarse liver with the space occupying lesion and minimal ascites, because of which he came to CMC for further management. He had a history of jaundice 30 years ago, where he was diagnosed to be hepatitis B, HPSAG positive, but no treatment was taken for the same. He is a known diabetic for 10 years on treatment and known hypertensive on treatment for 10 years. There are no addictions or any family history of liver cirrhosis or malignancy. On examination, they had mild splenomegaly and a BMI of 24. Investigations revealed some mild thrombocytopenia. HPSAG was positive. AFP was 5.6. HBV DNA was 3.9 million. Outside ascitic fluid analysis was high SAG low protein. So in view of the space occupying lesion in the ultrasound, we decided to do a MRI abdomen contrast. As we can see, there is a coarse shrunken liver along with a 5.5 centimeter lesion in segment 4 of liver, which shows venous washout capsule enhancement. Then there's another nodule in segment 7/8 of liver of size 5.2 centimeters, along with the arterial hyperenhancement and venous washout. There's no ascites or portal vein thrombosis or lymphadenopathy. So this is a diagnosis of cirrhosis of liver, MELD8, CTP6A, which is HBV related, HCC2 lesions in segment 4 and 7/8, BCLC B, port hypertensivitis, which is diuretic responsive, a non-bleeder status post-primary EVL, non-hypertension diabetic with a ECOG state 0. Multidisciplinary team meeting was done, where he was decided he was not, since he was not eligible for transplant at present, and in view of previous ascites, taste was also considered high risk, which could lead to further decompensation. Therefore, he was started on systemic therapy, tablet lenvatinib 8 mg for 3 months, along with the antivirals, tenofovir and beta blockers and glycemic control. So after 3 months of lenvatinib, here is a 2 MRI image wherein we can see that, that in segment 4, the lesion has shrunk. Now the size is 2.9 centimeter, along with the non-enhancing. In segment 7/8, the size is 3.8, along with disappearance of arterial enhancement. There are multiple studies with lenvatinib, of which I have taken one study which had 233 participants. In this study, there was complete response to lenvatinib in 20%, partial response in 44%, stable disease in 26%. In the study, the median duration of lenvatinib was 4 nights. So at present, we have asked the patient to continue lenvatinib for 3 more months. Option of liver transplant was discussed. The patient is yet to decide. Now the options of liver transplant versus continuation of chemotherapy is there. The learning point in our case is, in patients who are ineligible for transplant, lenvatinib can be considered as a monotherapy until they are eligible for transplant criteria.
Is that all, Ikram?
Yes, sir.
Okay, over to Alagamai for her initial comments about a vanishing tumor. You are on mute, Alagamai.
Why not taste, sir? Actually, bilirubin is good. There is no ascites now. Looks like a reasonable good candidate for taste. Is that not so? liver functions, the liver albumin is 3.5, bilirubin is normal. Though there was ascites, now when we saw there is no ascites and diuretic responsive ascites, looks like a reasonably good candidate for TACE, which was the first thought I had on seeing the case before the initiation of lenvatinib.
I think we would have thought about that, Alagamai, but at that point, because of two big lesions at 5 centimeter with ascites, we would have thought maybe it's okay to give lenvatinib to start with and see how things go. And we never expected it to totally shrink. So if there is no tumor, if no tumor
was
now.
Lucky that we fell into the category of responding patient. The tumor biology was good. Otherwise, we don't see this commonly in the practice. Like lenvatinib is given, practically it is given as a, something we have to give, so we will give something like that. Only it is being given. So good response, I think it is rare, though it is reported to be there in 20% of patients in the study, which is shown. I think I would have gone for TACE. I'm not sure. Like I understand that it was a very big lesion and 2 lesions were there and 2 separate segments. But the patient is lucky that he responded to lenvatinib. Now that we have reduced the size, probably he will become a good candidate for transplant.
So that is the question, Alagamai, and maybe I'll open it for Dr. Jayanti or others who can come in here. We haven't seen such good response with lenvatinib, such vanishing tumors. And if we have such response, do we offer transplant in this patient, suggesting a good biology?
CTP
CTP
score?
now is A bar B, early B.
Ma'am,
6A.
Ma'am, it's 6A.
6A.
6A. Today, there's a lot of discussion on SBRT, no? Almost SBRT has become the fashion of management of patients with HCC. And then they downstage it and go. I've really not seen an lenvatinib causing this type. I'm not certain how it's acting.
So I was wondering, ma'am, whether this repeat CT didn't show any viable tumor. So loco-regional treatment may not be now viable anymore. So doing an RT or RFA is not, or TACE for that matter, may not be useful. The only question would be, is it worth or thinking about transplant here? Maybe.
Sir, since we have a lot of data, even with patients borderline thrombosis, tumor thrombus, subjected to some form of bridging therapy and then taken up for transplant and showing a good response, I think we should offer for this patient transplant, considering nice shrinkage of tumor, no vessel involvement, very good functioning liver. We should offer because he's since he's having a good functioning liver, he's going to get more HCCs as we wait. More lesions can come up. We should offer transplant. Even with tumor thrombus, people are doing so. We should do for this case.
Can I ask Dr. Jayaprasad also, because I understand that they run a hepatitis B clinic as well. Dr. Jayaprasad, do you see such patients, and about Dr. Ikram as well?
Actually, we are not seeing that much cases, sir. We just now started the cleaning. We are following up only. We are treating only uncomplicated cases. Complicated cases, we are referring to model centers where they are treating complicated cases, sir.
Sure, sir. Dr. Ubal, Dr. Piram, any thoughts on this? Would you be happy to offer transplant here?
That was just what I mean. I was alluding to what Dr. Alagamai was saying. As we wait, there may be new HCC forming. But on the same count, if we transplant, is there a very high risk that they will have a recurrence? Because
yeah, so I would have thought high risk of recurrence, and I wouldn't have offered. So my initial thought was we'll just wait for some more time and see. Maybe Dr. Ubal, what does he feel?
I also agree with Dr. Alagamai, and maybe TACE or something else should have offered, because already the patient responded very well to chemotherapy. Maybe we go all out and eradicate the tumor. Transplant maybe a little later if it is anything is maybe the initial offer will be a TACE.
Okay. Shall I close this? Thank you, Dr. Alagamai. Thank you, Dr. Jayaprasad. Thank you, Dr. Ikram. We'll now move on to the next session, and it will be a surprise to us as well what will come out. It is a from Dr. Sairam. Is he ready
Surprise to the moderator also.
Yes, it will be, it will be. So let's see what he presents. Sairam?
I think we will upload it from here, I think. So, Sairam has sent us videos here.
Okay.
To upload. So takes just a minute. We can start.
Yeah, no problem.
Good evening, one and all. Vellore is famous not only because of its fort and its history, but also because it's a home for personalities who excelled across various fields. We shall be meeting now one such personality who held the Indian flag high in the international sporting arena, Mr. Satish Kumar Sivalingam. Mr. Satish Kumar is the son of the soil, born and brought up in Vellore. He comes from humble origins. He did his schooling at Government Higher Secondary School, Vellore. His father, Mr. Sivalingam, an ex-serviceman, works now as a security guard at VIT University, Vellore. Mr. Sivalingam himself had won gold medals at the national level in weightlifting, and he was the mentor for Mr. Satish Kumar in his initial years. Mr. Satish Kumar is the first Indian male weightlifter who won gold medals in consecutive Commonwealth Games, 2014 at Glasgow and 2018 at Gold Coast, Australia. He also represented India in the 2016 Olympic Games in Rio de Janeiro. He was conferred the Arjuna Award, the second highest sporting honor of India in 2015. He is currently the coach of Indian national weightlifting team. Welcome, Mr. Satish.
So weightlifting is completely, we are fighting with the anatomical structure. So weightlifting, just for 2 hours. So you are doing 3 or 4 months continuously for the preparation for the competition. And the competition only 2 hours. Weightlifting, there is no heats, no semi, no quarter, no final. There is only one chance. Because it's weightlifting.
Age of 14, 15, you first came to gym. Like what age you came?
13, 14.
14.
14. Before the simply general activities. Running, jumping, pull-ups, push-ups. At the time, I don't have any idea.
For example, இதே situation எங்க வீட்ல இருக்கு அப்படின்னா எங்க வீட்ல கண்டிப்பா வந்து they would have, of course அப்பா இங்க இருக்காங்க 10th exam இருக்கு 10th exam முடிச்சு பார்த்துக்கலாம் அப்படின்னு
எங்க வீட்ல அதேதான். எங்க வீட்ல வந்து 10th exam வந்துச்சு. First training proper exam different mindset. So there's a lots of person who are studying now. But there's a limited person, limited supporter parents. For my parents, they told the exam is a other thing. First thing is a training. Don't leave it. Up to 12th standard. அதுக்கப்புறம் நான் வந்து பட்டியாலா போயிட்டேன். 2010ல வந்து பட்டியாலா போயிட்டேன். ஃபேமிலி சப்போர்ட் until now ஃபேமிலி சப்போர்ட் இல்லாம இந்த அளவுக்கு இது பண்ண முடியாது. அது mandatory thing.
At the age of 13, you started training under your dad. Then subsequently, after class 12, you went to Patiala for training. So how many years you have trained before your first year? 4 years.
2010, 2009 is
till 2014. 2014 was first Commonwealth. Okay. That was at Glasgow. Were you confident enough in the first attempt?
Confident இருக்கும். என்னன்னா best.
But win பண்ண உடனே உங்களுக்கு எப்படி இருந்தது?
That's all magical moment. Lifetime encounter. நல்லா இருந்துச்சு. ஃபீல்ஸ் அதுக்கப்புறம் என்னன்னா இன்னும் மோட்டிவேஷன். இதுக்கப்புறமும் இன்னும்.
So how are you fighting injuries? But how do you fight it mentally?
So at that time, just to motivate yourself. This is nothing but motivation. So self-motivation, very major.
Okay. So who do you consider as your inspiration, as your role model?
Inspiration, whoever have willpower, even also not like human also. You go and see the animals, you go and see some other things like machinery also. If you will find there is some wear and tear happen, but still it's running like that's also like willpower. Willpower. It's working behind the limit. Yeah, that's the experience. If you see the birds and
everyone or everything who has a willpower,
willpower
is
and who is fighting themselves. Whatever happens, we need to fight and we need to come over from
one
message. Life journey is very precious. Make a goal. Like goal, I want to achieve this thing, and make sure you are comfortable with it. Make a goal and ready for fight. Clear vision and just follow your rules, goals, and make a separate path. By the end of the path, you will find the beautiful place. All of the road, there's a beautiful things also. Just enjoy the things and go and achieve the beautiful thing.
We, the Tamil Nadu chapter of Indian Society of Gastroenterology, on behalf of the medical fraternity, are proud of your achievements and wish you all the very best in your future endeavors. This is a small token of appreciation from our society. Thank you.
Thank you, Sai Ram. May I request Ubal for some few comments as moderator?
Thanks. I think I know this must be Epan's idea. So it is nice because we have a lot of regional talents. Apart from medical field, I know the CMC have a lot of medical stalwarts in other fields also. So fortunately, you have chosen a field which is outside the medicine, and it is very nice to see. And Satish Shivlingam is speaking about some of the points I noticed is he says in weightlifting there is only one chance, so utilize maximum. So that is a very important point. And he also said self-motivation and willpower. He quoted even animals and machinery. So usually if we ask for some motivation, we have some individual, but he said even animals and machinery is a give a motivation. And so as he said, make a goal and follow your own rules and reach a beautiful place and enjoy the journey. And very well done. I think sure others you do a quarterly meeting also. This is a 5 minutes nice presentation. Nice Sriram. I think probably you have spent quite a lot of time and edited the video, and it was nicely came out. Good, very good. Keep it up.
Thank you, Dr. Ubal. I'm pretty sure this will be matched by other regions as well in future e-meetings. This is a section that I think Dr. has rightly suggested, Dr. Epan's brainchild. So every region is encouraged to have a non-clinical, non-academic small presentation. With this, can I now invite Dr. Katie Shenoy, our esteemed guest for the day. He is a well-renowned hepatologist, not only in India, world over, and is currently in Population Health and Research Institute, Shri Kokulam Medical College and Research Foundation. And he is going to talk to us on the Trivandrum fatty liver cohort. And to chair the session, we have another two gastroenterologists and hepatologists from the north, and we have Dr. Kaushik Das. Welcome, Dr. Kaushik. He is heading the Department of Hepatology at Institute of Postgraduate Medical Education and Research at Kolkata. Thank you, Dr. Kaushik, for joining in. And we have Dr. Rohit Gupta, who has joined in from AIIMS Rishikesh, and currently he's the head of Department of Gastroenterology and Hepatology at AIIMS Rishikesh. Thank you, Dr. Rohit, to join in as well. Thank you very much.
Thank you. Thank you, Dr. Ashish.
Over to Dr. Shenoy.
Can you hear me?
Yes, sir.
Thank you. It is a pleasure to be associated with the Tamil Nadu chapter. And I must have placed on record the invitation by Professor Epan and also Dr. Uday, Dr. KRP, Professor Jayanti, and Dr. Ubal, Dr. Ashik. So the screen is visible now?
Yes, sir.
Okay. Now, what I will be doing is to take you through the journey of research undertaken by me over the last 20 years. So I have titled this talk as Collaborative Research Way Forward, Experience at Trivandrum. And the Population Health and Research Institute is an NGO which I started way back in 2006 when I retired from Trivandrum Medical College. So this slide shows you the journey of research. India, research is of low priority. It is not because of the resources available. It is because we don't have good mentors. We don't have a collaborative approach. We don't look at each other as equals. And that is the reason why the collaborative research is not the rule, it is an exception. The first 1 or 2 minutes I will touch upon the collaborative research which I have undertaken. The first one in India, we have a lot of doubts about tuberculosis and Crohn's, and we do not have any biomarkers. So it was in 2007, I met with a gentleman from Norway, Arne Roseth, who discovered the calprotectin as a biomarker for ulcerative colitis. So we sat over dinner and then he asked me, do you think of any research which you can undertake? I told it will be better to do TB versus Crohn's. And within a period of 2 years, with 5 centers in India, myself, then Dr. Thayumanavan from Madurai at that time, Dr. our VGM from Coimbatore, and a few others, we could accumulate 38 patients of Crohn's and 39 cases of tuberculosis as a part of a PhD program for Norway University of Oslo. And we could produce 4 research papers in high index journals. Subsequently, we had collaborations on non-alcoholic fatty liver disease, a clinical trial with a metadoxin across 8 centers starting from Srinagar down to Cochin, our center, Coimbatore, and then Dr. S.P. Singh and Dr. Ajit Sood from Ludhiana. Again, this was a very successful collaboration. We had many collaborations in the field of HBV and HCV clinical trials. But what I am going to discuss today is the equation between ourselves and our foreign collaborators. The first such equation which I struck was with Michael Q from South Africa, Johannesburg. When I met him in the IST meeting or the INSAL meeting in CMC Vellore, I think it was somewhere in 2008 or 9. We sat over lunch and I was telling him that I wanted to study the genotypes. So he was very helpful. He gave all the help without any financial commitment from our side. And we collaborated with the Johannesburg, the Center for Genotyping Research with Anna Kramvis. And we found for the first time, it is not Geno D, it is the Geno A, which is 80 to 85% in the population of Kerala. But my mentor for clinical research and for epidemiological research was none other than Professor Richard Pito from Oxford. I think in research we have serendipity. It was in 1995, I met with Professor Pito at Mexico in the International Clinical Epidemiology Network meeting. And he asked me a very pointed question. Are you interested in epidemiology of tobacco? I told yes, because it has a high morbidity. And every minute, 6 people are dying in the world because of tobacco-related illness. He was immediately taken back and he told me, come to my room and we will write a project. Over 2 hours, we wrote the first project of a large prospective study for tobacco and health. With $1 for a subject recruited, we recruited 1,000 subjects. And the prevalence was very interested. It was something like 39 to 40% prevalence of smoking. And he called me to present this at the World Conference of Tobacco at Paris in the next year. And then we had a discussion with the Director General of WHO for the funding. It took me 4 years from 1996 to 2000 to get funding for a large prospective study of 4 lakh people, 3 lakh rural and 1 lakh urban, which I completed in 2000 to 2004. And on the basis of this large prospective study, I undertook a smaller studies such as piggyback. And what I will describe is how we can piggyback a research on an existing cohort. So we had Guru Aital meeting me in Guwahati, again INSAL in 2012. And within 2 days, we wrote up the project. And what I will be discussing mostly is the success of this project of NAFLD. We have collaborations with Spain on chronic pancreatitis. We have collaboration with Professor Bruno and Brunito on HBV, the surface antigen, various small particles, small, intermediate, and large. We have collaboration with the France International Agency for Research on Cancer, on diet and epidemiology. In Sweden, we have a collaboration with the NASH, looking at microbiota. We have also a collaboration with the Karolinska Institute on GERD, looking at microbial flora in the esophagus and stomach, H. pylori and non-H. pylori bacteria. I'm not going to discuss. Finally, we have collaboration with the Mayo Clinic and with the Kansas, Pratik Sharma and Nicholas Talley on epidemiology of GERD. So what I'm going to describe is this large cohort of tobacco, which I'm putting here, started in 2000, along with my 2 mentors here, Professor Dahl and Professor Pito. Dahl is no more, he's a gastroenterologist in Middlesex Hospital, interested in smoking. He described the physician study on lung cancer and smoking for the first time. And Pito was his student. I was fortunate to work with him from 1995, and the collaboration continues. And the study was funded by a large fund from Fogarty Foundation, clinical trials, and the British Heart Foundation. What I will be discussing in the next 13 minutes is my journey with Professor Guru. Guru hails from Kota near Udupi. So we had a good equation because we speak Kannada. Over the dinner in 2012 in Guwahati, he asked me, are you interested in NAFLD cohort? I told, why don't we think about it? And we set up a cohort of something like 12,000 we wanted to recruit. But when we started the cohort, we found the prevalence of NAFLD was very high. And this picture shows the inaugural camp of this cohort on 13th of February 2013. We started initiating in 2012 February, but I had to get all the permission to take the ultrasound to the population, to set up a laboratory, to set up a team, to get the stratified sampling. And we were able to do a multi-stage clustered sampling, which has been described. So any collaborative study not only requires funds, it requires a good interaction with the community. This picture shows you myself with the local MLA, Mr. Karthikeyan, Shabari Karthikeyan. He was son of our minister. He's a very, very dynamic politician. His wife is the collector. She's a doctor. And this was one of the camps, the 5th camp, which he himself wanted to come and address. And here you see in the upper panel, 3 of my researchers who came from UK. And then he was inaugurating and speaking to the people. The lower panel, you see my research colleague, Dr. Lena. The patient and the research, there is an interface in UK. All researchers work with something like a sandwich, who is a social scientist, who will make the research happen. So what you see him is this gentleman. Yeah, you can see me. And this was the camp, the 4th camp, where this is the photograph of the team of the NAFLD. It's a teamwork. You can see myself and my research colleague. and all the my partners from UK. Guru was not there. And you see on the extreme left, the person from Abbott, who gave me a machine, a fibro scan machine free, to be with me, a new machine to be with me for 3 years. I think I put on record my thanks to Abbott for helping me in this research. This is Mr. Muralidharan, who is the son of late Karnagaran, who was the chief minister. During one of the camps, he suggested that I also want to be with you. So I was not there because I was busy in the hospital, but he visited our campsite. And then you can see, these are the participants who are invited to the camp based on a cluster sampling at the population, where the data is collected in a tab. They are invited for the camp for ultrasound, fibroscan, and blood sampling, as well as a detailed dietary history. So you can see that every camp invitee has a card, as he has got an ID card. You can see here one person holding his ID. This ID is given to them at the time of registration, and this number is recorded into our computer. So you could see that these are the participants at various camps, and you can see blood sample being drawn in one of the rooms in the camp, and then the samples are processed immediately in the laboratory, and all the samples are stored in a liquid nitrogen in the can at the camp. They are taken to the central laboratory at the Population Health and Research Institute to be kept at -80, a deep freezer. I must also put my thanks to Professor Guru, who contributed one such a deep freezer. At the end of the study, he told, I want to equip you with more research so that I can give you a deep freezer, which you can do many more research. So we did the ultrasound. Doing ultrasound in the population is not very easy. You have to have the permission from the government that you will not do it in pregnant women. You will not use it for sex determination. You have to give the period in which the scan. So we have to get a scan. We did not purchase it, but we entered into a contract with the Mindray to give us a Doppler ultrasound scan, a portable one, which we took. And all these pictures are recorded and sent to Nottingham for further review. We had 2,200 subjects, and we have 2,200 files of the ultrasound, which they can review and they can see whether there was any problem. So this is the FibroScan room, where you can see the EchoSense machine. We don't have a FAT at that time. We did not have a cap for this machine, but we can look at the median stiffness. So all the subjects underwent the median stiffness in the population. So in summary, the study was a population-based cluster sample study similar to the population structure among adult males and females, irrespective of whether they have a disease or no disease, whether they are alcoholic or no alcoholic. All of them underwent the ultrasound, a detailed dietary history, a detailed physical activity questionnaire, a detailed sleep questionnaire, a detailed questionnaire on the quality of life, a questionnaire on anxiety and depression, the Duke scoring, an ultrasound scan, a blood sampling and storage of blood in -80, plasma, as well as EDTA for DNA, a fibro scan for the medial stiffness. So this was, in a way, the study took about 3 years, from 2013 to 2016, to accumulate approximately 2,200 subjects. And then we did all the biochemical parameters, the liver function test, HOMA-IR, and all the lipid profile, the hematological parameters. We also did the studies on CRP. And then the samples were aliquoted into 4 aliquots for future studies. We had 2 consent forms, one for the baseline data, and second is for genetic studies. As you know, for genetic studies, we should have a separate form, which is not the same consent, a different consent. So we have to do two consents. So this is again a fibroscan in one of these camps, and all the pictures are put in a pen drive. We saved them to be transmitted to Nottingham for their verification. Every study requires a social aspect. So in each year, the Onam is being celebrated with all the social investigators. And one of the Onam celebrations, we had Professor Guru in our office. So the lower panel, you can see Dr. Guru Prasad Aisal, myself, Dr. Leena, and my office staff. Those who are sitting are the social investigators. So this was a celebration when we finished each aspect of the study. So what I'm going to describe now is the various studies which we undertook in the Trivandrum NAFLD cohort. The baseline was 2013 to 2016. We had the first paper which came out on risk factors prevalence on non-alcoholic fatty liver disease. We had a prevalence of 49%. I will show you the paper. The second and third paper were describing the food frequency and the 24-hour food recall. How do they tally? That was the second paper. The third paper was the food frequency and the food tree from this particular cohort, which are published in Nutrients. Both are published in Nutrients. 2015, there was another study on brown fat among Indians and the Caucasians. So we are also involved. The same subjects, only males were included because females may have hormonal changes. The brown fat study, which was again published. We had the genetic studies, the Jivas, which is paper 5. We have started the next randomized control of fighting fatty liver. That is the paper 6, MR-PDFF, elastography and spectroscopy. We had the stool microbiota and metabolomics, which is being written up as paper 7. We have a liver stiffness and scarred liver in Trivandrum. In addition to this, we had 14,000 subjects from the population. This one I presented in the last liver meeting. This is under publication, paper 8. Now we are looking at the natural history. Between 2013 to 2023, we have 10-year follow-up for the first 500 patients. We have 8 years or 9 years of follow-up for the last recruitee. We had a COVID in between. So we wanted to study the impact of COVID. So this natural history looks into the COVID in those subjects. We collected samples from this and looked at the T lymphocytes. This is again being written up by Dr. Guru on COVID in NAFLD and their impact. So what I will give you is the papers which have come out. The BMJ Open is the first description of the cohort, 49.8%. You can see both adjusted and non-adjusted odds ratio. Summary of this: metabolic syndrome 1.62, diabetes 1.63, obesity 3.27, male sex 2.27, urban domicile. These are the important factors. An opportunity came to me to reanalyze this data, and with permission from Guru, I reanalyzed this data for the new definition, metabolically associated steatotic liver disease. The percentage prevalence turns out to be 48.3 because you have to have a fatty liver with a moderate alcohol consumption. You have to have a higher waist or a higher BMI or any other metabolic risk factors like diabetes. And then we had just to give a punch some of these numbers. And overnight, I analyzed this data. The adjusted odds ratio comes similar to what I have done in the NAFLD. So this paper will be written up very quickly, and it will come as one of the papers on metabolic steatotic liver disease. This is the paper which I was mentioning, the third paper, a food group group-based tree analysis in NAFLD and the comorbidities. 2,047 patients had a full dietary setup, a fully computerized diet with various factors. So 1,026 controls and 1,021 cases. 53 were excluded because they were, when we looked at the distribution, they were either under-reporter or over-reporters. Finally, 973 controls and 993 cases. 1,966, a very large number. And we did something called three-way analysis. Main food groups, the ingredients, and the cooking methods. I'm not going to describe the details, but to show you that we analyzed 361 recipes, 28 single food items, 2,165 individual ingredients. Every individual ingredient and of the 28 individual food items, 3 categories based on the food tree. And this is the food tree which we developed for the first time. It is a computer-generated food tree. I would urge you to look at the paper which was published last year in Nutrients. So this is the third paper which has come out. The fourth paper is being submitted to Nature Genetics, but I am going to give you, this is the abstract. We did the Jivas in 406 and 420 controls because we did not do everything at one time. We found out 2 different components in the principal component analysis. One is A and B. Look at this. They are distinct populations. A is very distinct from B. So Dr. Guru asked me, why don't you reinvestigate what is B and what is A? So I look at the database. All the B came from one particular camp. This camp was from 20 kilometers from Trivandrum. And I went into anthropology of that population. That population hailed from Madurai. They were working as flower vendors in Madurai Meenakshi temple 500 years ago. They migrated, some of them, and the family is settled. And when I took, they had this particular pattern, the pattern B, which is the distinct pattern from A. What is the difference? The pattern A, group A, 725 of them, the prevalence of NAFLD was associated with the PNPLA3 with an odds ratio of 1.43 with a very narrow confidence interval. The p-value was 0.002, but not with the TM6S superfamily. But in group B, interestingly, the prevalence of NAFLD was associated with TM6S, that is the superfamily, but not with the PNPLA3. So that the superfamily, it was 0.019. So this was a very interesting observation. And meta-analysis of the data from 2 subgroups using the SNP, the top hit was RS 1926203, which is intronic in the ACTA2, which has been implicated in hepatic stellate cell activation. In summary, the group B had the RAB3-GAP1, which is the guanine nucleoside exchange factor, playing a very important role in the hepatic cell activation. So we are trying to study further in this specific genotype with a larger population from this particular cluster. The third one is the fourth one is the brown fat, which was again presented in the hepatology meeting. South Asians are at risk of developing higher susceptibility of fatty liver. I will give you the summary. 28 Indians, 10 NAFLD, 14 controlled males, 32 UK South Asians, and 51 UK Caucasians were studied using a thermal imaging method, a very difficult method to quantify brown fat. We have to have fully air-conditioned, temperature-controlled room. We should have a bath, a ice bath. We should have a thermal camera, and we have to take the photographs from the supraclavicular fossa and the interscapular region. And we also genotype the TRPM8. The interesting observations are the possession of the TRPM8T allele is associated with the increased BAT activity. BAT is the brown adipose tissue. Environmental factors interacting with the lower prevalence of T allele may result in a reduced BAT activity. So this is again being further evaluated, and a manuscript is under preparation. This is the showing the distribution, the box plot. You can see that there is a good difference between the CC and the T variants with a p-value of 0.006. Finally, I will touch upon the outcome from this study. This is a randomized controlled trial. 2018, I was with the Guru in a meeting in Nottingham called as the Nottingham Showcase. I gave him an idea that why don't we try fighting fatty liver in Trivandrum. My research colleague, Dr. Leena, is a proponent of yoga. So she wrote up a project of yoga, and then me and Leena were there in the meeting. So we put up this proposal, and within a month or so, Dr. Guru came back to me telling me that we are going to submit it to the Research England as an innovative project. This was the only innovative project selected by Research England to be funded between 2018 to 2019 with a grant of 1.6 crores for a very large project, a mechanistic hypothesis to be drawn between fighting fatty liver using two different modalities. One is diet and yoga, replacing white rice with red rice and cereals, and yoga compared to yoga alone in about 85 participants using a simple random sampling, 16 weeks therapy. The modality for quantifying fat was MRPDFF and the spectra analysis, which was done way back in Nottingham in one of their MR units. The body composition was measured. The diet was taken in detail. The stool samples were collected for metagenomics, and we had the urinary microbiome, the metabolomics as well. This is the yoga in practice during this session. The two groups were given separate yoga practices, and all of them we selected only males because females have their periods and they may be able to do yoga, not able to do yoga. So this is one of the yoga camps, and the team there below you can see the team in my office. So the yoga and the health gave us a lot of insights, and then I will just close my sharing the slides. Can you close it down or? Okay. So I have taken you, Dr. Epan, a big journey of mine, which started as a piggyback project with my large project in tobacco in 2000 to 2004. We still have the follow-up of the tobacco, and we have 9 cohorts which we have built in. One is the GRD and FGD cohort. We have the cohort of microbiota in the esophagus and stomach. We have the fatty liver. We have the HBV cohort with the genotyping. Currently, we have 2,461 subjects in HBV being followed up for the long-term sequelae with genotyping. I thank you for giving me this opportunity to be with you and discuss the journey of a gastroenterologist doing research in the field of public health. Thank you.
Thank you very much, sir, for that inspiring talk. Can I open up for initial comments from Dr. Rohit and Dr. Kaushik?
Thank you, Dr. Shenoy, for taking us through this wonderful journey. You have done some excellent work, both molecular, genetic, and community work. So my congratulations. And being a young gastroenterologist, it's really motivated us and all the young gastroenterologists sitting in the audience. It would have really motivated them to do good work in gastroenterology. And maybe if I could ask you one question. So how big is your team? How many people help you? Because you have so many 8-9 cohorts. And
Okay. Let me tell you. In 2000 to 2002, I had a funding of about 8 million. 8 million rupees. And I had 152 research workers with me. When I started the cohort between 2000 to 2004, I had to complete the cohort in 4 years, 400,000, including all the field work, imputing the data, looking for 10% follow, 10% of them are re-interviewed for variations. And that is the pattern of a prospective study. So I had something like 150 people. But between 2004 to 2023, I have now 25 people working with me in my office. I have 4 data entry operators. I have 2 defreezers. I have minus 24 defreezers. I have something like 50,000 biologic samples. I have no vehicle. I don't have any vehicle. Everything I get it from outsourcing. I have a computer entry for all the things again outsourced. I have put my infrastructure to a small extent so that the expenditure will be very minimal in my office. So when you start a cohort, as you go, your funding will come down. Then I have to take a piggyback and get my. So that is how I take my research forward. By 2004, my major funding has come down. So at that time, I approached Karolinska Institute, which gave me funding through the SIDA. I applied for SIDA Foundation and SIDA gave me funding. Then I approached a number of other agencies who gave me bits and bits of funding. So I was able to take the team forward. But one thing is very important. My research coordinator is with me for the last 33 years, starting from medical college, 1986 to 2023. And you see her photograph. She is my co-investigator in all the projects. She is the author in all the publications. She is the young scientist of Kerala. I asked her to go and present. She got 2 awards. She went for 8 epidemiology trainings in Florence, WHO to equip her for epidemiology. Basically, I think you do not, many of you do not know me. I have my master's in epidemiology from Australia, from University of Newcastle in Australia. I did it in 1996, 97. So since I trained in a clinical epidemiology, one of the mandate for me was to do clinical research and teaching and training. So I hope young people like you should really look into the population and you can do extremely unbiased research. You can do not 1, you can do 10 research, you can put in all the resources. And the most important thing, your mentor should be in the same equilibrium like you. Your mentor should have the same biochemistry. And I would be able to get a good biochemistry between me and Professor Pito. Pito is a top. He's a world-class notch, nominated for Nobel Prize last year. He's a top-class scientist. So you have to work with them. But doesn't matter, they all look at you as equals. I think that is where I find the problem in India. We don't look people as equals. I don't want to give more because it is being recorded. So I tell you, if you want to take a young research colleague and you are a mentor, treat them as equal. Put them in all publications. Give them an equal weightage, an equal consideration. In all these publications, you will see me and Lena share the same citations. We give that we contributed equally. We don't say we contributed more. One doesn't contribute. In some, for example, MTTP gene mutation journal of hepatology, it came up. I gave the samples to Dr. Guru in my study from Karolinska with the Rolf Fulkrantz. Rolf Fulkrantz is no more, but he was my collaborator in 2005. So I gave the genotyping sample to him, and he worked at that particular sample for the MTTP gene mutation. And he asked me, I'm going to put you as a co-author. I told, since I have contributed, I think I have a right to be a co-author. So Guru and me don't have any difference. We work equally. He may be 10 years younger than me, but doesn't matter. In research, I think we have to treat each one as equal. That is my message if you want to do research.
Thank you, sir. Thank you, sir.
Thank you. Thank you very much, sir. Dr. Kaushik is another person who is mentored by Dr. Abhijit Chaudhary. Dr. Kaushik, your comments.
What can I say? Just I have learned a lot of things from Professor Sinha. Actually, may I have just one point from want to know from Professor Sinha. Is there any plan to developing biobanking system or any kind sort of thing in your institute? How do you plan for that? Just for learning.
No, you asked me a very pertinent question. To learn biobanking, I went to Oxford University. I looked at the biobanking of the UK Biobank. You know, there is a UK Biobank. So Professor Pito took me to the UK Biobank. The biobanking in various facilities. Oxford is there, Cambridge is there. So he was kind enough to drive me from Oxford to Cambridge. And then I had the biobanking in IARC in WHO, where I collaborated with one of the top scientists. So biobanking, you should have a barcoded vials. You should plan your biobanking. The biobanking can be done in two ways. Either you can spin the sera, or you can plasma. You can take the puffy coat, or you can take the EDTA. You can use small tubes. There are small long tubes where you can fill with blood and cut them and keep them. That is what is done in the UK Biobank. But here, I use the cryo vials, 250 microliters in each of these cryo vials, but they are kept in different freezers. They are not kept in the same. One helicot is in one freezer, other is in another freezer. And I have a catalog. I know where it is kept. It requires a tremendous effort. Easy to say, but very difficult to maintain.
Thank you, sir. Thank you very much for an interesting session. I'm pretty sure we all would have gained from your experience. At the peak, we had around 110 participants. Piram, I think we achieved what we aimed for, Tamil Nadu ISG, and I think a lot of students would have benefited across the state. I thank all the participants, Tamil Nadu ISG for their support, all the speakers, all the moderators, Tiruvannamalai Medical College, who was the partner institute for us in this presentation. And I thank Dr. Piram and his technical support for this. At the end, I'll again place my thanks for Professor Shinoy for a very inspiring talk. Thank you, sir.
Thank you. Thank you, Ipan, and all of you. It was nice to interact with you. I want all the youngsters like Kaushik and others to be inspiring the young graduates to take up and mentoring them. I think mentoring is a very important thing which we should take up among either ISC Tamil Nadu and ISC Kerala, because we have bright students, but they want to be mentored. Thank you very much.
Thank you, sir. And we'll conclude here till we meet again 3 months later. Thank you.
Thank you.
Thank you, sir. I think to place on record my thanks to Professor Eapen and all this team for putting up such a good program. It's very informative. Again, Professor Shinoy has been an inspiration to learn from him. And thank all the participants, the faculty who have given their time for this program. I hope it was of use to all the students as well. So hope we have more such programs in the future as well. Thank you so much.
Thank you, sir.